Welcome to our webinar, Managing Your Practice During COVID-19. I'm delighted to have as our guest today, Dr. Carlos Portu from Shoreline Physician Group. My name is John Michael Carter, the CEO of ChartSpan. Dr. Portu, welcome, and perhaps a little bit about your background and your practice's background.
Thank you, John. Thank you for having me. In terms of, my practice, I think we have a pretty typical traditional primary care practice. I'm the only physician in our office. I have a nurse practitioner. I have a reasonably sized office with about 5 full-time employees and a few part-time folks that help me in a few different capacities for some of our ancillary services. It's outpatient only. We don't really do any kind of inpatient work. And we're sort of doing this and learning it day by day as we go here to try and continue to operate in a world with coronavirus, COVID-19, and however long this ultimately lasts for.
Let's begin there. When you think back over the last 3 weeks, what were you prepared for and what were you not prepared for?
Yeah, I think that kind of one of I think the benefit of an independent practice is your ability to kind of adapt quickly to changes in situation without the typical bureaucracy that's involved with an employed practice or a larger hospital group. There tends to be a lot more policy to deal with. In an independent practice, you can pivot pretty quickly. So I think we had already sort of circled the idea of telemedicine in the past, and reimbursement was not particularly efficacious or fruitful. With the changes on behalf of CMS, I think it's made it a lot more compelling to add telemedicine as part of our medical practice, and we were able to do that part very quickly. I think from a supply standpoint, we were not particularly well prepared. I mean, I don't even have an office manager, so I manage all of our inventory and supply ordering for the office with the assistance of my staff, and my front office staff manages front office materials, and my back office staff, medical assistants, nurse practitioner, manage our back office medications and medical supplies. And we really never considered this scenario and how we would work through it logistically as part of our supply ordering process. And really, by the time we gathered the idea that we were going to have to deal with this, even though it's been a month or a month and a half, it was pretty much impossible to get any kind of materials from McKesson and Henry Schein and some of our typical suppliers. So we've had to use the secondary market, anything from Amazon to eBay, to try and procure some of those materials to keep our staff safe, our patients protected when they are occasionally in the office, and help us manage our day-to-day operations.
Yeah, extraordinary. It's unbelievable that we don't have enough medical supplies for providers on the front line. Let's talk about how you're triaging patients. So I think maybe contrasting how you saw patients 3 weeks ago versus how you're seeing a majority of your patients today, and how you're deciding that a patient may be symptomatic, and then how do you deal with that patient?
Sure. Well, it's really hard to imagine a world from 4 weeks ago, right, before we were doing this. Typically, my normal office workflow was that we tried to do as little as possible over the telephone, even when it came to results, simply because number one, obviously reimbursement is a component to that, and typically out-of-office communications was poorly reimbursed, and it was kind of a loss of provider time when you spend a lot of time on the telephone reviewing results with patients. So our workflow was typically to have diagnostics and testing and lab work or imaging performed, and then have the patient follow up to review those results in office and do a lot of the post-visit management right here in the office when a patient was ready to leave in our quote checkout process. Now we literally are doing it the opposite. We try to bring the patient in as little as humanly possible. Oftentimes, we'll do a routine 3-month follow-up for a diabetic patient, and they never will step in foot through the office during the course of that process. We'll see the patient, or they'll do their laboratory studies in advance of a telemedicine visit, and then we'll set them up for a telemedicine visit and go from there. A few of the common procedures that we do, everything from Prolia injections to B12, vaccinations, so on and so forth, INR checks for our AFib patients, we do them drive-through. So the patient contacts our office when they get to the parking lot downstairs. We're on a second floor. They let us know what automobile they're in, and we ask them to please wear a mask when they're contacting with staff. And I send a staff person down there with masks and gloves to do their Coumadin check or to give them their vaccine or their B12 shot and come back up. And we try to treat, unfortunately, every patient like they could potentially have coronavirus. And really, it's for the protection of the patient and the patient that comes after them and the staff, because ultimately, if we have to quarantine the office, all the typical normal healthcare problems that we manage for our 3,500 plus patients in our panel are going to be very difficult to accomplish.
You mentioned that you adjusted quickly to telemedicine in your office. What about your patients? Because you're in the Naples area, I suspect you have a large cohort of elderly patients who maybe aren't as technically savvy as a younger cohort. How have your patients adjusted to telemedicine?
Yeah, I think that the majority have done reasonably well. We went through a couple of telemedicine solutions at the very onset. The first one was a little too complex for patients. It required downloading an app and then utilizing that app in order to communicate with us here at the office. And we found that as basic as we could potentially make that while maintaining appropriate HIPAA compliance was the best option for us. So we actually went away from the one that was integrated with our EMR solution. And despite the fact that it takes a little bit more work on the staff side, it is much simpler for the patient. We use one called doxy.me, which simply requires our patients to type in a web URL, enable their video and audio, and then we can take it from there. And it's HIPAA compliant and meets all the requirements. Obviously, there are some temporary waivers, and occasionally when patients still have that challenge of being able to do even that minimal functionality, we'll use alternative methods of communication like FaceTime that are even simpler for patients. We use iPads as part of our typical office check-in process, not any presently, but in the past. So all of our providers have an iPad, even our medical assistants have an iPad, and they can FaceTime patients. And I think video provides just that little extra sense of normalcy to a very abnormal process that our patients are suffering through. And it's nice when you can see the facial cues that they're giving you when you're discussing a medication or what they need to do to feel better, and vice versa. They find reassurance in knowing that they can see you even if they're really not seeing you live and in person. And there's a real value to that.
You reference the discrepancy in the reimbursement for telemedicine prior to 3 or 4 weeks ago. CMS has made so many changes around telemedicine in the last 3 weeks. Frankly, it's hard to keep up with them all. And so one of the changes they made was they said, okay, we're going to reimburse telemedicine encounters like a traditional face-to-face E&M encounter. So that was critical for adoption. I think everybody understands that. As you look at the decisions that CMS has made, what do you applaud and what do you still want to see them do to help you run your practice better and maintain the care for your patients?
Yeah, I think that really what has been the most dramatic to me is that, CMS has always been I think generally is well-intentioned while trying to curb abuse. But ultimately, when it comes down to it, I think that healthcare is most efficient and most effective when we empower doctors and other medical providers to use their discretion in most effectively communicating with their patient population. And when it comes down to it, the reality is that the number of items in a review of systems that I checked off, or how many boxes I clicked on a template to generate a note to achieve a certain level of complexity per CMS guidelines, is really ludicrous and has very little to do with ultimately the effort and time that goes into managing complex or even not complex patients. And it's both heartening that with a crisis like this and the swipe of a pen, a lot of these regulations can go away. And I think it should serve as a reality check that a lot of these things are slowing us down from adapting care models to really take the best care of patients possible. And I think over time, perhaps it's a lesson that trying to fact check doctors by requiring arbitrary, quantifiable objects within a clinical note is really just not the way to ultimately drive good care or to make our healthcare delivery system effective and efficient.
Reimbursements are often decided year over year based on your quality scores. If you're a part of an ACO, you're obsessed with well care because so much of the MSSP savings distribution is based on how you perform on certain quality measures. At a moment like this, how are you thinking about well care versus sick care appointments?
Well, I think that the world marches on, and depending on where you are in the country today, you either have a lot of coronavirus and upper respiratory issues to try and manage for your patients as an outpatient, or you don't necessarily have a lot. I think that with the advent of telemedicine, addressing things like HEDIS measures and other types of core measures and addressing chronic medical conditions is actually way, way easier than it used to be because we can do very simple problem-focused visits to try and address those types of metrics for the health insurers that before would have required the inconvenience to a patient of bringing them into the office when really they didn't have a whole heck of a lot going on in their minds. But for us as clinical providers trying to meet all the different metrics that we try to accomplish in the course of a year, there's generally not enough patient touch points to get all that stuff done. So we've taken advantage, and with obviously some of the downturn in some of our ancillary services and other things that require face-to-face interaction, we've tried to fill the gap and accomplish some of those ACO and insurance company driven metrics that they look at us to portray quality. And we've tried to drive those scores up using modalities like telemedicine. And I think at the end of the day, if telemedicine continues to be as effective as it has been, it's going to be a great tool to accomplish a lot of those objectives.
You scrutinized and ultimately hired us, ChartSpan, to run your chronic care management program. How has that program helped you and served your patients during COVID-19?
I think it's really been a very, very big asset to the practice, and there's numerous reasons why. I'd say first and foremost, for a lot of our patients, particularly those that have chronic medical problems and that fit in the category of chronic care management, those patients benefit a lot by just frequent reassurance. And the idea that somebody is there, available, and touching base with them on a regular basis provides a pretty big advantage to the patient, both from a clinical perspective to try and address some of their chronic issues, but just from a reassurance standpoint that, hey, I've got somebody that I can call anytime, day or night, with whatever question crosses my mind. And to us in the office, that provides a real significant value. I think the secondary part is just from a backup standpoint, when you start to think about logistically, well, what am I going to do in the event that some of my front office staff is unable to come to work, or if we have some providers that are unavailable to come into the office, how are we going to manage that? Knowing that a subset of our population will be able to access some amount of clinical support, even with our limited in-office staffing, provides a really significant advantage to managing our patient population. So I think that overall, the benefit is really significant. A third one is just disseminating information. Obviously, we've always tried to be on the cutting edge of communicating with our patients on a regular basis, whether it's through email programs like Constant Contact, our patient portal, social media. Chronic care management is just another way that you can get a message out to your patients in terms of what's going on, what do you need to be doing every day to be prepared for the current situation, and how is my healthcare provider available to me.
Speaking of chronic care management, we want to remind our viewers that ChartSpan last week launched our COVID-19 Rapid Response CCM program. It removes a lot of the barriers it takes to get a program up and running. So once we have access to your EHR, we can stand up your program in 24 hours or less, and we've removed minimum patient panel sizes or long-term agreements. And we've also developed onboarding and training services that allow us to remotely get your program up and running so we don't clog up your patient waiting room. And we also can maintain the safety of your patients as well as our own staff. Dr. Portu, we appreciate your candor and your time today. Thank you.
It's been a pleasure. Thank you for everything that you guys are doing.